Hello, this is Eric Strong once again, and today I will be discussing the topic of rate and axis. The learning objectives of this lecture are to be able to calculate the heart rate from an EKG of both regular and irregular rhythms, and to understand the meaning of the QRS axis and be able to determine it both qualitatively and quantitatively. Before I begin, I would like to point out that determination of rate and axis can occasionally seem like an unnecessary exercise taught more for historical reasons than for practical ones. This is because modern EKG machines contain a computer algorithm that will automatically calculate the rate and QRS axis and include these values on the EKG printout. They are almost always located in the upper left, where the QRS axis is denoted by this middle number here. The adjacent numbers refer to the P and T wave axes. The reason one should be able to determine the rate manually is twofold. Sometimes you'll need to figure out the rate on a device that is not a typical EKG machine, for example, a printout from a portable cardiac monitor that one might find in an ambulance. Second, although very uncommon, the EKG algorithm sometimes gets the rate wrong. This can occur when the QRS amplitude is very small or when the T waves are excessively prominent. As with the rate, the algorithm rarely miscalculates the QRS axis, doing so only when the patient has an indeterminate axis discussed later in this lecture. However, the manual determination of axis serves as an excellent practice by which the medical trainee can become familiar with thinking about the directionality of the electrical processes of the heart with respect to the location of specific EKG leads. Comfort with conceptualizing vectors of electrical current in the heart is of great importance in EKG interpretation of abnormalities such as ventricular hypertrophy, ischemia, and a variety of unusual rhythms which the algorithm usually gets wrong. I'll discuss rate first. There are two general techniques to determining rate. I call the first technique the 300 rule. Just to remind you, an EKG is essentially a visual representation of the voltage in the heart as a function of time, as seen from the surface of the chest wall at various locations. Conventional EKGs are printed on red or pink graph paper, consisting of big dark boxes which are subdivided into light small boxes. These small boxes are 1 millimeter in width, which, unless the machine is otherwise programmed, is equal to 40 milliseconds. Therefore, a big box is 5 millimeters in width, or 200 milliseconds. How can one use this information to determine rate quickly? And what does the number 300 have to do with it? To answer this, let's do some simple dimensional analysis. The final value of interest is beats per minute. How do we get to those units with our big box equals 200 milliseconds relationship? We know that there are 60 seconds in a minute. If there is one big box for each 200 milliseconds, then there must be 5 big boxes for each second. Finally, to get the units to work out, we can ask how many big boxes correspond to 1 beat. Multiplying this all out and canceling units provides the very simple relationship heart rate in beats per minute equals 300 divided by the number of big boxes between beats. It's that simple. For example, here is an EKG. What is the rate? We can see that there are 3 big boxes between adjacent peaks of the QRS complexes, so the heart rate is 300 divided by 3, which is 100 beats per minute. Another example. In this case, there are 8 big boxes between QRS complexes. The rate is thus 300 divided by 8, or 38 beats per minute. You don't even need to have a traditional 12-lead EKG for this technique. Here is a single lead rhythm tracing, and the same analysis applies. So there are 2 big boxes between beats, therefore the rate here is 150 beats per minute. Although the math is extremely basic, most clinicians will make this process even more automatic by memorizing this table, which is nothing more than the factors of 300. An important exclusion criteria to being able to use the 300 rule is that it cannot be applied when the ventricular rhythm is irregular. In this situation, one needs to use the 10-second rule. This rule utilizes the fact that each lead in the traditional 12-lead EKG is recorded for exactly 2.5 seconds. As there are 4 leads across the EKG duration is 10 seconds. 10 seconds divides into a minute 6 times, therefore the heart rate in beats per minute is approximately equal to the number of beats across the EKG times 6. For example, in this EKG of atrial flutter with variable AB block, we can count 17 beats across, which can be counted on any line. Then the heart rate is approximately 17 times 6, or 102. A second example. Here is some atrial fibrillation. In this case, there are 22 beats across the page. Thus, the heart rate is a rather quick 132 beats per minute. That's all there is to determining the heart rate on EKG. Axis is a little more tricky a topic, but still easily mastered with a little practice. The QRS axis represents the average direction of electrical activity in the heart during ventricular depolarization. So here's a heart in the thoracic cavity. At different points in time during ventricular depolarization, there will be vectors of electrical current throughout the heart. In reality, this is a contiguous wave of depolarization. Thus, while I have only a couple of individual lines drawn, I could just have easily drawn 10 or 100 or 1,000 vectors at any point in time. As depolarization of the ventricle proceeds, the direction of these vectors changes. The QRS axis is essentially the mathematical sum of all of the hypothetical individual vectors to provide a single direction which, as stated, represents the average direction of electrical activity. The QRS axis can technically point in any direction in three-dimensional space. However, in most circumstances, we are only interested in the projection onto the frontal plane of the net electrical vector of ventricular depolarization. Therefore, axis is usually reported as an angle on the frontal plane using the classic hexaxial reference system shown here. So thus lead 1 points directly to the left and is assigned 0 degrees by convention, and lead AVF points directly inferiorly and is assigned positive 90 degrees. In some circumstances, one might want to also calculate the QRS axis in other planes, such as the so-called transverse QRS axis using the precordial leads. Doing this quantitatively is rare. However, a qualitative assessment of the transverse QRS axis is very common, but is usually referred to as assessment of the R-wave transition. The R-wave transition point will be discussed in another lecture. And unless otherwise specified, the term QRS axis should be assumed to refer only to the axis in the frontal plane. Deviation of the QRS axis from normal can provide insight into chamber enlargement, abnormalities of the conduction system, myocardial infarctions, and the origin of some arrhythmias. One problem faced by anyone attempting to determine and interpret the QRS axis is to be able to compare it to normal. A QRS axis less than normal, that is more negative than normal, is considered a left axis deviation, frequently abbreviated LAD. A QRS axis greater than normal, that is more positive than normal, is considered a right axis deviation, or RAD. Unfortunately, there is no consistently applied normal range for QRS axis. In addition, when the axis reaches the zone between positive 180 and positive 270 degrees, it is called an extreme axis, superior axis, or indeterminate axis. Be aware that usage of the term indeterminate axis is incorrect, as it means something different that I'll discuss in a few minutes. To give you an idea of the variety of opinions as to the range of normal QRS axis, as well as opinions regarding terminology, here's a summary of what is described by leading EKG textbooks. Here's the very popular, the only EKG book you'll ever need, which divides the 360 degrees of the frontal plane into 4 quadrants, with a normal range 0 to positive 90, the range of positive 180 to 270, the latter of which is also equal to negative 90, is termed extreme right axis deviation. Here is one of my favorite EKG texts, Marriott's Practical Electrocardiography, the range of normal axis is slightly expanded, and extreme right axis deviation is instead referred to as just extreme axis. Chow's electrocardiography in clinical practice, which is as close to a definitive text in general EKG interpretation as there is, defines an even broader range of normal axis, along with some additional terms. Finally, a large number of internet resources, as well as common usage, divides the range of possible axes into 4 equal quadrants, but then subdivides left axis deviation into pathologic and physiologic. While there isn't a consensus regarding the normal range, nor the terminology, here is what I use in my practice, which conforms with the common practice of electrophysiologists with whom I'm familiar. The normal range is -30 to +90. An axis of -30 to -90 is termed left axis deviation. Axis within +90 to +180 is right axis deviation. And finally, the remaining quadrant can either be called extreme axis or alternatively superior or right superior axis. One of the difficulties faced with defining normal is that there are several non-pathologic factors which affect the QRS axis. The first of these is age. At birth, people actually have a rightward axis, attributed to the fact that the right ventricle is relatively more massive, as pulmonary vascular resistance is higher than systemic vascular resistance in utero. Within several months after birth, axis normally shifts to around +60 or so, and then over a person's subsequent lifetime, it will gradually drift further leftward, such that the average axis in normal elderly patients is in the neighborhood of +15 to +30 degrees, with some differences between gender. Another factor is body type. Tall and thin individuals tend to have more of a vertical axis, closer to +90, while short and obese individuals tend to have a leftward axis closer to 0. Before discussing the specifics of how to manually determine the axis, I must first review an extremely simplistic way to classify QRS complexes by morphology. They can be predominantly positive, where the area under the curve formed by the QRS complex is predominantly above the baseline of the EKG tracing. The complex can be predominantly negative, or the complex can have equal areas above and below the baseline. This type of complex is most frequently referred to as an isoelectric complex, which is a poor term since the word isoelectric more implies a flat line segment at baseline. Therefore, I would scratch this term and replace it with equiphasic. Once again, an equiphasic complex encloses equal amounts of area above and below the baseline. As with determining rate, there are 2 different techniques to determine axis. One is qualitative, and the other is semi-quantitative. The qualitative one is the quadrant approach. With this, one examines the QRS complex in leads 1 and AVF, focusing on whether it is predominantly positive or negative in each. Then one uses the chart to determine which quadrant the axis lies in. If the QRS in 1 is positive and the one in AVF is negative, you may be dealing with left axis deviation, or normal. If this happens, the next step is to look at the QRS complex in lead 2. If it is predominantly positive there, the axis is normal, and can be further narrowed down to -30 or 0 degrees. If the QRS in 2 is predominantly negative, the patient has left axis deviation with an axis between -90 and -30. To see how to apply this, let's look at an example. For this EKG, the QRS in lead 1 is predominantly positive, and that in lead AVF is also predominantly positive. Referring to the table, this gives us a normal axis. Let's look at 4 more very brief examples. How about this EKG? QRS in lead 1 is predominantly positive, while the QRS in lead AVF is predominantly negative. This puts us into the LAD ? Category, so we need to go to the next step and examine lead 2. Lead 2 is predominantly negative. Therefore, this patient has a left axis deviation. In this case, the QRS is predominantly negative in 1, while the QRS in AVF is predominantly positive. Thus, this patient has right axis deviation. In this EKG, both the QRS in 1 and in AVF are predominantly negative, so this patient has an extreme axis deviation. Finally, in this example, the QRS in 1 is predominantly positive, while in AVF is predominantly negative. We need to look at lead 2, which we can see is predominantly positive. Therefore, this patient has a normal axis. So that's the quadrant approach. After just a little bit of practice, using the table to the left will become second nature. While this approach is very simple, its downside is that it is qualitative only. That is, it does not provide an estimate of the actual numerical QRS axis in degrees, other than placing it into a broad category. In situations where a more precise numerical estimate of axis is desired, the equiphasic approach is preferred. The first step in the equiphasic approach is to determine which limb lead contains the most equiphasic QRS complex, which I'll subsequently refer to as the equiphasic lead. In order for the QRS complex to be equiphasic in a particular lead, the average direction of electrical activity over the duration of ventricular depolarization must be 90 degrees away from the angle of that lead. So the next step in this approach is to determine which lead lies 90 degrees away from the equiphasic lead. Finally, if the QRS complex in the second lead is predominantly positive, the direction of this lead is approximately the QRS axis. If it is predominantly negative, the QRS axis is 180 degrees away from the direction of this lead. Let's look at how to apply this to an actual EKG. As we look at this example, ask yourself, which of the leads contains the most equiphasic QRS complex? It appears to be lead AVL. The equiphasic QRS complex does not necessarily need to be the smallest in amplitude as it is here, but it helps to identify it when it is unusually small. For step 2, we must refer to our hexaxial reference system for our 6 limb leads. By definition, AVL is at negative 30 degrees. 90 degrees clockwise is lead 2 at positive 60. For step 3, we look at the QRS complex in this lead and determine if it is predominantly positive or negative. It is predominantly positive, so therefore our QRS axis is also approximately positive 60 degrees. I'll go through 2 more examples of this approach. In this case, AVR is most equiphasic. AVR lies at positive 210 degrees in our reference system. 90 degrees away from this lead is lead 3 at positive 120 degrees. The QRS complex in lead 3 is predominantly negative. Therefore, the QRS axis is 180 degrees away from the direction of lead 3. 180 degrees away from positive 120 is negative 60. Thus, the axis is approximately negative 60 degrees. This example is a little more tricky because there really isn't a clear equiphasic lead. So we must choose the closest thing to one, which I think is lead 2. You'll notice that lead 2 is obviously more positive than negative, but the adjacent lead in the reference system, that is lead AVF, is clearly negative. This means that the actual transition point from being predominantly positive to predominantly negative occurs somewhere between leads 2 and AVF. So therefore, one can imagine a virtual equiphasic lead just clockwise of lead 2. Again, this virtual lead lies between 2 and AVF because 2 is positive and AVF is negative, and it lies closer to 2 because 2 is more equiphasic than AVF. What lies 90 degrees away from this? Well, that would be a virtual lead just clockwise of AVL. So let's look at the QRS complex in AVL. It's predominantly positive. So therefore the QRS axis is approximately equal to -30, and to be more precise, it is ever so slightly inferior to -30. The computer algorithm for this particular EKG had calculated an axis of -22. There is just one more situation concerning determination of axis to discuss. This is the case of the indeterminate axis. This occurs when all of the limb leads have a QRS complex that is equal parts positive and negative. That is, all of the leads appear equiphasic. This is most commonly seen in COPD as a manifestation of the pulmonary disease pattern of low voltage, poor R wave progression, tall P waves, and unusual axis. That concludes this lecture on the determination of rate and QRS axis of the EKG. If watching this on YouTube, please feel free to leave comments or questions or share with your colleagues.